Good evening, everybody. Thank you, Mr. Chairman, and thank you, Dr. Bugdadi and the organizing committee for inviting me today to talk to you about eosinophilic esophagitis. Since last year, there was a drug that was approved, the first drug to be approved by the FDA in order to treat such patients. So there is a light at the end of the tunnel from that aspect. These are my disclosures. So what we're trying to do here is differentiate EOE from other types of food allergy using evidence-based guidelines and diagnostic criteria, analyze current and emerging treatments based on their impact on disease outcomes in patients with EOE, as well as employ strategies to effectively transition adolescent and young adults patients with EOE from pediatric to adult care. So by definition, eosinophilic esophagitis is a chronic, largely food antigen-mediated disease. It's characterized clinically by esophageal symptoms and histologically by the presence of more than 15 eosinophils per high power field on the biopsies. And there are some genetic and environmental factors that play a role in the development of the disease itself and its complications. From an epidemiological standpoint, the disease has been increasing worldwide. We can see in the graph in the 90s, and till now, the incidence is about 5 to 10 in 100,000 persons per year. And the incidence and prevalence has been increasing at a higher rate than increased disease recognition itself. From a pathophysiological standpoint, eosinophilic esophagitis really is a T helper cell 2 inflammatory response that is mediated by IL-4 and IL-13, which are the key and central drivers for these type 2 inflammation. We can see here the Th2 cells with the mediation of the interleukin 4, interleukin 13, as well as interleukin 5, drive the eosinophils as well as the beta cell class in order to destruct the barrier on the esophagus, cause the barrier disruption, cause the fibrosis, as well as eosinophil trafficking to the tissues, leading to the dysphagia and the fibrosis, the chest pain, as well as the esophageal narrowing that we see in these patients. The delay in diagnosis is very important because it has been reported up to 20 years, and that delay can result in fibrostenotic disease and delay in therapy for these patients. And the progression of significant fibrostenosis in most patients with over a decade of untreated EOE. And the majority of the delay happens when patients are less than 20 years old. So what are other conditions that are associated with eosinophilic, with esophageal eosinophilia? The most common one is reflux, which we deal with on a daily basis. Obviously, EOE, other eosinophilic gastritis and gastroenteritis diseases, echalalia, hypereosinophilic syndrome, Crohn's disease, inflammatory bowel disease can have an increase in eosinophils in the esophagus, infections, connective tissue disease, as well as hypermotility syndromes, and other etiologies that can really have to be differentiated from EOE before we make that diagnosis in order to optimize our therapies. Patients with EOE really have significant atopic comorbidities like IgE-mediated food allergy in about 2/3 of patients, allergic rhinitis, atopic dermatitis, as well as allergic conjunctivitis, asthma, and urticaria, as well as angioedema. It does have a burden, EOE has a burden on healthcare, and we can see here the financial burden, the high cost of care, especially when we delay the diagnosis with the missed school as well as work days for these patients. And these patients have a chronic disease that require lifelong treatment. From a clinical feature standpoint, the prevalence is three times more in common males than females that affect all ages. And the prevalence is up to 23% of patients undergoing endoscopy when they have dysphagia. And the most common causes of bolus food impaction is EOE. So we have to differentiate the symptoms in young adults, in children, as well as late in childhood. So initially, with toddlers as well as older children and adolescents, the symptomatology is not dysphagia. Usually they have feeding difficulty, feeding refusal, poor weight gain, and even regurgitation and vomiting. And as we advance in age, symptoms can progress to abdominal pain, retrosternal pain, as well as dysphagia because of the development of fibrostenotic disease and food impaction. So these patients typically have what we call adaptive behaviors, and these can mask EOE. It's labeled as the impact, which is imbibe fluids to facilitate the passage of food, modify the food, prolong meal times, as well as avoid foods with hard textures, as well as chew extensively and turn away tablets or pills. So what is the diagnostic algorithm for EOE? We have the clinical presentation that is suggestive of EOE, and the gold standard for diagnosis is upper endoscopy with biopsy. Even if the mucosa is normal, we do biopsies if we have a high rate of suspicion for these patients, depending on their symptomatology. And once we do the biopsies and we see more than 15 eosinophils per high power field, then we have made the diagnosis of EOE. And the endoscopic findings, we have to alert ourselves, especially when we have a suspicion for EOE. It can range from edema, which are the ERAFs, which can range from edema to exudate and furrows in patients with inflammation, or develop rings or strictures in patients who have fibrostenotic disease and have the disease for a long period of time. And again, endoscopic findings alone do not reliably establish a diagnosis of EOE and require evaluation of esophageal eosinophilia from the biopsies. Histological features also can help. We'll look at the epithelium as well as the lamina propria. And these, we have to alert our pathologist to look for these in order to detect the final or the proper diagnosis. What about diagnostic things other than upper endoscopy, which is the gold standard, as I mentioned? There is some office-based esophageal tissue sampling ways that we can collect the tissue sampling rather than expose the patient to upper endoscopy multiple times. We have the cytosponge, the esophageal string test, the confocal microscopy capsule, as well as transnasal endoscopy, and esophageal mucosal impedance. The cytosponge in UAE, it does have a good sensitivity and specificity, 75%, 86% is well tolerated, and it's pretty good correlation with upper endoscopy from a pathological standpoint. The esophageal string test, which really quantifies the esophageal associated protein. It's a capsule that the patient swallows and you leave it there for an hour. It collects those proteins. It does have also the good specificity and sensitivity in comparison to upper endoscopy. Transnasal endoscopy, it has gained a favorable approach regarding the decrease in the amount of time that the patient spends in the hospital, as well as the no need for sedation, and as well as a reduced cost. From other emerging technologies, the endoscopic ultrasound as well as the endoflip can be used in these patients. So from an EOE standpoint, treatment-wise, we want to treat to target. I got this from the IBD. We treat the target, so we have to treat the bug. Now we're doing biologic therapy, so we have to look for the target in our approach to therapy. We have to improve our symptoms. We have to improve our histological activity in order to reach less than 15 eosinophils per high power field, as well as the endoscopic activity, whatever symptoms and the ERAFs, as well as the symptoms that the patient has. So the spectrum of response ranges really from histology, symptomatology, as well as endoscopy standpoint. If we have a no response, we still persist with the more than 15 eosinophils per high power field, where we have a complete response if you have less than one, and a response when you have a reduced eosinophilia of less than 14, between 1 to 6 will be an excellent approach at remission for these patients. From a symptomatology standpoint, obviously, if we have more than 90% decrease in the symptoms, then we have a complete response, and a non-response in the persistence of symptoms. And from an endoscopic standpoint, we look at the ERAFs, grading them, and we look at the normal esophagus if you achieve complete remission, or the persistence of these endoscopic findings on repeat endoscopy. So for a treatment algorithm, the initial therapy should be either a diet therapy or with a combination of medical therapy, use of proton pump inhibitors, or topical corticosteroids. And if the patient does have a stricture, they need dilation. Dilations have been proven to be safe with a perforation rate of between 0.3 to 0.5% only in multiple studies that have looked at this. And this is a chronic disease that can recur after we stop the therapy. So maintenance therapy is very important if the patient has persistent symptoms or have not been responding nicely. So we start with elimination diet. Really, it's effective. It prevents the use of medications with its adverse events. And the challenge is that it requires multiple upper endoscopies, adherence from the patient, and an effort from the patient and the family itself, especially when dealing with children, and requires organization and motivation from patient itself, difficult to implement when feeding difficulties are present, and most require access to specialized dietitian and can be costly, and not sufficient environmental allergens really trigger the disease. So the types of elimination diet, the most important one is cow's milk. We have the 6-food elimination diet that includes the cow's milk, wheat, egg, legumes, the peanuts, and the fish with seafood. Studies have looked at the 4-food elimination diet as the 2-food elimination diet. And the 2-food elimination diet, the most important allergens in these patients are the cow's milk as well as wheat. And there are recent studies about 1-food elimination diet achieving even as good as a 6-food elimination diet. And start an elimination diet really in all patients willing to implement dietary changes for that aspect. And here, this study looked at the histological remission rates based on dietary intervention between children and adults. And the more diet restriction, the more histological remission you can see here. So this can be, from an elimination diet, it can be approached as either a step-up approach, with start with a 2 up to 4 up to 6-food elimination diet, or a step-down approach. The caveat here that every time you alter the diet, you have to repeat the endoscopy and to see where you're standing. Does the 2-food elimination diet first did achieve what we're looking for with the remission in the histological standpoint? If not, then we go up to the 4 up to the 6-food elimination diet in order to identify which food is the major underlying cause of the patient's symptoms. Or you go on a step down approach, as I mentioned, and you go one by one, but unfortunately you have to do upper endoscopies for all these patients in order to document whether they have responded or not. So from a therapeutic standpoint, we start proton pump inhibitors usually because they're really safe, they're very effective, easy administration, and low cost. And the histological response goes at a rate of 42%. They have anti-secretory as well as anti-inflammatory effects, but we have to start with double dose rather than once a day. We can use topical steroids. There's no formulation that is approved by the FDA. Histological remission with less than 15 eosinophils, the rate is about 65% and provides really topical coating to the esophagus and safer and similar efficacy to systemic steroids. And it does have some side effects, including candida infection in the mouth and the esophagus. And the oral formulations of fluticasone and budesonide are currently being studied. So you can use topical steroids, whether you use budesonide or inhaled fluticasone. Really, the studies have shown that there is no difference, and I'll show these studies now. It's just important to really educate the patient about how to use both of them, which is very important to have the best benefit and the best effect from that aspect. If we start with oral budesonide, which has improved histological and symptom response versus placebo in patients with EOE, excuse me. We can see here with this study, it looked at randomization of budesonide oral suspension versus placebo, and the stringent histological response of less than 6 eosinophils per high power field. We can see that the response rate is 53 in comparison to placebo at 1. And similarly, the dysphagia symptom score we have a response from it, but unfortunately, it's not statistically significant. From a maintenance therapy standpoint, EOE is a chronic disease, and when treatment is discontinued, relapse typically occurs, and the maintenance therapy should be considered in all patients. And according to the AGA and the Joint Task Force guidelines, topical corticosteroids should be continued in patients who achieve remission over discontinuation of treatment. From a budesonide or dispensable tablet, which at this study looked at the maintenance of remission after 48 weeks, and we can see that the maintenance remission have been achieved in about 75% and 73% with no statistical significance between the dose used at 1 milligram twice a day or 0.5 milligram twice a day. And the risk of recurrence on topical steroids for more than 48 weeks is very low, as we can see. What about the difference again between budesonide and fluticasone? And this study really looked at the comparison between the two, and we can see that there's no difference regarding the peak eosinophil count as well as dysphagia symptoms questionnaire between the use of fluticasone or oral budesonide from baseline to post-therapy standpoint, as well as a histological response looking at the different eosinophils per high power field, whether it's less than 15, less than 5, or less than 1. We can achieve both, whether you use budesonide or fluticasone, as well as the EOE endoscopic reference score, the EREFS. Also, both are comparable between budesonide and fluticasone. So which steroid formulation, looking at the meta-analyses for fluticasone as well as budesonide, obviously these are not comparing apples to apples, but the response rate from a fluticasone standpoint is 68% and budesonide is about 77%. So what are other biologic therapies that can be used in patients with EOE? Anti-IG is not recommended, anti-IL-5 only in studies right now. and montelukast, as well as immunomodulators and anti-TNFs are not being recommended at the current time. It's just used only in context of clinical trials. And now this is the new kid on the block, which is the dupilumab, which has been first approved by the FDA for patients above the age of 12 last year. And it's a human monoclonal antibody that inhibits IL-4 and IL-13. And it really blocks the cytokine-induced inflammatory response to reduce type 2 inflammation. As I mentioned, the dose is 300 milligrams subcutaneously every week. It does have some side effects locally with injection site reactions, as well as upper respiratory tract infections, arthritis, and herpes viral infections. So really, dupilumab studies with random, this is the cohort study and how the planned study was done. In part A and part B, part A, they randomized patients between placebo and dupilumab 300 milligrams subcutaneously every week. And part B with dupilumab 300 milligrams subcutaneously every week or every other week or placebo. And after a follow-up of 24 weeks, they switched the placebo in part A to dupilumab 300 milligrams subcutaneously every week with the other arm, which is every week with the dupilumab, and switched the placebo in part B to either 300 milligrams subcutaneously every week or every other week. And the co-primary endpoints were histology, remission of less than 6 eosinophils per high power field, and a symptom change in the dysphagia symptom questionnaire. And we can see here that dupilumab have reduced the dysphagia symptoms in patients up to 24 weeks and about 27% reduction, as well as 69% reduction in comparison between the placebo as well as the dupilumab. And with the follow-up of up to 52 weeks, there was a reduction up to 75% in dysphagia score at week 52. From a histological remission standpoint with dupilumab, the response rate, which is less than 15 eosinophils per high power field, was 82%, and the remission rate, which is less than 6 eosinophils per high power field, was 56%. And if you follow up the patients up to 24 weeks, the normalization, which is the stringent criteria, normalization of having no eosinophils per high power field on the biopsies was 21% of patients. And if you follow them up to 48 weeks, the response rate with no eosinophils was 29% achieved with dupilumab. So what about monitoring? Repeat endoscopy with biopsy no earlier than 4 weeks after changing in diet and 8 to 12 weeks after a change in pharmacological therapy. And the goal is really reduce symptoms, reduce eosinophilic inflammation, as well as histological remission, as mentioned previously. What other biologics are currently being investigated for use in the patients with the EOE? We have the tezepelumab, the bernalizumab, the larintelimab, and cendakimab, and etrasimod. Etrasimod have been approved for patients with IBD. And these are still investigational drugs and have not been approved for our use with EOE patients. It does require a multidisciplinary approach with a multidisciplinary healthcare team in order to take care of these patients with gastroenterologists, even allergists, immunologists, as well as dietitians and all the other healthcare providers in order to optimally treat these patients to the max. What about transition of care? We really, as physicians, we are not doing very good from that aspect. And healthcare transition can be a vulnerable time to patients and physicians alike, as well as the parents and the families. And 78% of patients, 76% of parents report no knowledge of healthcare transition. And the factors associated with a lack of knowledge is really older age is disease diagnosis, already seeing an adult gastroenterologist, or parents of children on steroid therapy. And the mean preferred age to initiate transition is really between 18 to 24 years, and recommend to begin transition initiation discussion even at age 12. So what about the challenges in transition of care? It has a patient and parent specific barriers as well as provider specific barriers. From a patient and parent specific standpoint, there's not an independent, the patients are not independent from parents. There's non-adherence to medications and not familiar with the clinic location and logistics, as well as non-adherence to follow-up appointments. Whereas providers, there's no formal transition program, and dietary therapy with nutritional support needs, inadequate insurance coverage, as well as transition readiness not assessed. There are some systematic barriers like inadequate or absent communication with the referring physician and inadequate knowledge about medical condition. So the 6 core elements really for adolescent transition of care is discuss transition policy, track the progress, depending on the age, obviously, of the patients, assess the skills, develop the healthcare plan the patient needs, including medical summary, and transfer to adult-centered care and integrate into adult practice, as well as confirm transfer completion and elicit consumer feedback. In conclusion, EOE diagnosis requires high index of suspicion, especially in an atopic patient. Dysphagia is less common in children. IgE-mediated food allergies are more common. Not all esophageal eosinophilia is EOE. Consider alternate diagnosis. Adequate full esophageal visualization and sampling is needed for optimal diagnosis. And current EOE treatment options, dietary, elimination, PPIs, and topical steroids. And dupilumab is really the first biologic therapy approved for EOE. It provides an important alternative in patients with moderate, severe, or even complicated disease. Dilation is an important aspect of EOE treatment and can be safely done upfront or after initial therapy. Thank you for your attention.